Well, thank you so much for joining us today. Those of you that have tuned in, it's been a very busy day with the congressional spending bill, and everybody is digging in and trying to figure out how it's going to impact the future of Medicaid and Medicare. But today, I have the privilege of moderating a panel. The session title for our panel is Meeting the Movement or Meeting the Moment, Innovative Care Models for High Need Dual Populations in 2025. And joining me today is Rizer, who's the Executive Vice President at ATI Advisory, where she leads consulting services and growth for states and Medicaid managed care efforts and dual eligibles on the Medicare side. Also joining is Dr. Julius Bruch, who is the CEO and co-founder of Isaac Health. We'll be hearing from him today about the program that he supports for brain health and dementia care. We have a very short webinar and we've got some talkers that are on. So we're going to try to maximize our time and we're going to jump right in, just setting the stage. Certainly, there's been a lot of efforts around dual integration, both on the Medicaid side and Medicare. We've been working for years to try to improve integration for members. We know these members have high utilization of long-term services and supports, high utilization of acute care services, and perhaps within the spectrum of Medicaid and Medicare spending, really are the population that are in fact the most important to focus on timely access and cost avoidance. So we've got some questions and we'll jump right into the first question. Let me just welcome our presenters and also those of you who've tuned in. So question number one, dual integration has certainly been a priority for federal and state partners. And despite these efforts, there's still key challenges that exist and opportunities seem endless to improve integrated care. We've seen prioritization of D-SNPs, we've seen FIDE-SNPs and HIDE-SNPs as a pathway to achieve integration within the system. So while we understand the goals for effective integration, what do you see as the key challenges and opportunities that still exist before us? And I'm going to start with Allie.
Yeah, thank you, Gary, and thanks to everyone who joined the call today, and Julius and Carissa for the opportunity to have the conversation. So this is a huge question. What are the challenges and opportunities with respect to integration? I'm going to throw an acronym around a lot today, which is D-SNP. Gary already started to throw a few of them around. I'm guessing everyone knows what that is, but if you don't, it's a dual eligible special needs plan. It's a type of Medicare Advantage plan, and it's been around for 23, 22 years now. So we've been at it for 3 decades. I think in the 90s is actually when Minnesota and Wisconsin started their first integration demonstrations using authority that kind of predates where we are today. And then, as I mentioned, D-SNPs have been around now since 2003 with the Medicare Modernization Act. And, you know, I think a lot of why it was a slow walk at first, at least, is because D-SNP, that's kind of the main chassis that we have for integration today, was a demonstration. So every year, 2 years, Congress would say, all right, we're going to kick the can down the road 1 more year and we'll let the demonstration continue. Or actually, no new enrollment this year. Yes, we can allow enrollment this year. And there's a lot of hesitation in the market when something is a demonstration. I think we're seeing this with VBID, another acronym, right now, the value-based insurance design, where CMS last year at the end of the Biden administration said, we're going to stop this demonstration kind of unexpectedly. The market doesn't like that. They don't want to invest a lot of resources and time and energy and then have the carpet pulled out from under them. And at the same time, we were experimenting in the late single digit 2000s. I don't even know what we call that decade. And then the early 2010s with MMP, right? The Medicaid plan demonstration. And so it was kind of like the let 1,000 flowers bloom. And then in 2018, suddenly Congress said, actually, we're going to permanently authorize special needs plans. And around the same time, and they required integration with it. And around the same time, we see CMS saying, you know, we want Medicare Advantage plans to serve people with complex needs. So we're going to incentivize them monetarily. We're going to pay more for dual eligibles. So you got increased payment, you've got a permanent program, and you see all of a sudden an enrollment in D-SNPs kind of skyrocketing, right? We're about 65% now. The market's getting pretty close to saturation. 65% of duals enrolled in Medicare Advantage, 45% in D-SNP. And so the slow walk, and then all of a sudden an explosion in 2018 with enrollment. but is any of it actually integrated? So like FIDE, HIDE, these fabulous acronyms that are just starting to become more of the sort of around the dinner table, I'd like to think. But none of it is really integrated. Even the most integrated products have separate care management teams, separate enrollment teams, separate provider networks. You know, behind the scenes, even some of the most integrated plans are not integrated. And there are a number of high-level reasons for this. We've got two regulators, right? At the end of the day, it is a state and a federal program. It's Medicaid and Medicare, and you've got two sets of regulations. Even in an integrated product, you got two sets of regulations. You have different payment streams. You're gonna hear me talk a lot about money. Follow the money. You got Medicare dollar, Medicaid dollar. You gotta tell CMS what you're spending on Medicare. You gotta tell a state what you're spending on Medicaid. So you can never really integrate if the system is set up in a way that kind of forces you to pull things apart. A really big thing is the money. States have different underlying Medicaid managed care program designs. Some duals aren't in Medicaid managed care. Some duals are, but maybe some of their services aren't. So like we really have this messy system where we've kind of forced a fragmented experience. In my opinion though, so this gets to like but it's not all bad. Like we're getting there. The opportunity side of it, I'm just going to touch on it and then be quiet for a moment. In my opinion though, something that is possible within the current policy context is a focus on integration of the dollars between Medicare and Medicaid, specifically at like the provider payer level. So if you are spending dollars on a Medicare service and it prevents Medicaid utilization, or spending dollars on a Medicaid service and it prevents Medicare utilization, are there value-based care models that can support aligning incentives across those two payers? The answer is yes, but it's hard. And to date, nothing has really done that. But that to me is where I see sort of this next level of integration opportunity emerging. So I will stop there because I have a lot more to say, but you know, we have more questions and then I'll go deeper as we get through the conversation.
Allie, thank you so much. I think you described it as messy. I've often described the system as clunky, but I think they both mean the same thing. And I think as you think about dual integration, if you've got two people in charge, then really nobody's in charge. So
Yeah.
I do agree completely with the way that you've described. Probably more challenges, but lots of opportunities. So question number two, when we think about the potential opportunities around affecting the rising cost and around chronic and cognitive care demands, we know that there's a tremendous opportunity as we look to dual eligibles. And so one of the conditions that's common within the dual eligible population that's uniquely tough to manage is dementia. And so this question is really for Julius. And why does dementia pose such a challenge for duals? And if you would tell us a little bit about the program you operate that has already proven success in reducing acute care utilization and improving health outcomes.
Yeah, absolutely. So you're absolutely right, Gary, that dementia and cognitive impairment are challenges that particularly impact dual eligibles, and that's why we really believe that that is sort of a prime area where we do need this next generation of integration. So some of the reasons why it's such a challenge is, first of all, it's just a high prevalence. The average Medicare Advantage plan has a dementia prevalence of 12%. In most dual populations, this is more like 30 to 40% and more. And that's obviously because dementia very much makes you eligible for Medicare in many cases, but also really creates the need for those LTSS services that are covered by the Medicaid side. And so really it's a high cost condition for both Medicaid and Medicare. And that's really what makes this such a challenge. But what makes it even worse is that there's such a low diagnosis rate. So very often, while so like 40% and plus have dementia, actually usually only 40% or 50% of those actually have a diagnosis. And that, as we all know, is obviously critical for getting the reimbursement through the risk adjustment model. So one way that how Isaac Health supports dual eligible plans is so first of all, through that identification, and we have sort of well-established mechanisms now through analytics to identify the population that is undiagnosed and to really sort of screen reach out and enroll this population, and that obviously addresses that underdiagnosis issue. But then what we do from there on is really manage that population in an effective way. And dementia is really sort of one of the conditions where increasingly specialist support is required. So we provide sort of the ongoing management through very much focused on the cognitive care needs, ensuring that this population stays as independent as possible for as long as possible. And this, what we've seen is, first of all, fantastic outcomes on the Medicare side, so the medical cost side, where we've seen reductions of 20% and more from reducing ED admissions, hospital admissions that are all potentially avoidable. And but also on the Medicaid side, so we've seen significant reductions in the nursing home admission rate, for example, and sort of in generally the Medicaid covered services needs. And so really it's a program and a condition that's really calling out for better integration here between Medicare and Medicaid. And that's why the dual eligible population, really benefits from a program like Isaac Health.
That's great. And despite the coordination challenges that exist, it's great that we are focusing on disease or chronic condition specific pathways. We've seen a lot of that in Medicaid. We know it works very well, can be real tricky. Again, kind of point to Allie made around, all the different regulations and all of the different financial accountability that exists on both parts of the system. I think having two experts in this space, and with all that's happening, and I keep telling people, just hang tight. There's lots of uncertainty, but the good news is we're beginning to see some clarity around at least what's being proposed, and that makes it so much easier to wrap your brain around what is rather than what could be. But Allie, I want to go to you. Having been in this business for a long time, both from a health plan perspective and now with your role at ATI, what advice would you give to states and health plans about where they should focus over the next 12 months? So I guess I'm asking you to pull your crystal ball out. We've seen a lot, certainly in our careers, and we've seen so much improvement. But what do you think the future looks like around integration?
Yeah, I like living in the crystal ball space for what it's worth. So I love this question. I mean, the trend that we've seen is over the past 5 years in particular, but I guess you could say to the past 10 years, a shifting of integration sort of oversight to states. So we've got a Medicare program and a Medicaid program. But until recently, states were kind of like, I don't understand Medicare, understandably, right? They're spread thin, they know Medicaid. And so we're going to let Medicare run this D-SNP program over here. And then we see them starting to really tap into their authority a few years ago, because D-SNP, most people may know this, but some may not. D-SNP is the only Medicare Advantage program the state has authority over. And states are increasingly really using this authority. So even before the change in administration, we were kind of watching this thinking, well, gosh, we're going to see even more of a shift towards states. Because of Chevron deference. Now, I don't need to get in the weeds of legal this and legal that, but essentially, like states would have maybe more flexibility even than they did in the past in the federal government to interpret federal statute. So we already thought it was going to be going down that path. But now what we see is a new administration coming in. We have MMCO, the duals office, that anyone who has an MMP or D-SNP product knows that office really well. Any state working in this space knows that office really well. And with DOGE, with the efficiency efforts underway right now, the part of the duals office that was providing technical assistance to states was eliminated. And we see Congress, this bill that you mentioned at the very beginning, Gary, we see Congress, trying to cut costs in Medicaid, trying to pull some dollars back from states. So we've got states ostensibly now with less technical assistance, fewer dollars, but there's this trend towards states. So it's like, how does that all kind of come together? And I think one thing is, candidly, integration has always been a nice to do. Like, it's a very important thing, and it's a very strategic thing, and it will bring in costs and improve care and all of that. But it's not entitlement, right? It's not like a population you have to focus on. It's not a thing you have to do. So it almost becomes even more of a nice to do now, but it can be a cost saver for states. So if I'm a state and I've now got to do more with less, I would be engaging my health plans and my providers. There's still some technical assistance coming out of the CMS offices in different ways, and more that we'll see come out, I think. But I would really be engaging my plans and providers on, how do I advance integration? What does it look like on the Medicare side? What do I need to know if these are my goals? And the flip side, if I'm a health plan, you better believe I'm going to be meeting with my state Medicaid agency or the aging department, like whoever it is that oversees DSNP and integration, and saying like, this is how you should be thinking about programs moving forward. Just like if I'm a provider, I would be in there talking to my state saying, this is the value I bring here. So you need to be thinking about moving forward on your duals program designs. I do actually think, so like the duals office issue aside, the state funding issues aside, I do think we will continue to see a very strong push toward dual eligible efforts under this administration and future administrations. Integration is a bipartisan issue. We have seen for years now efforts coming off of the Hill with Republican and Democratic senators working together to really push these proposals to require integration. So you have seen it over several administrations at that level, and you've seen it through Congress at a bipartisan level. So it will continue. And what we're really hearing right now is that there may be a pretty specific push in CMMI, yet another acronym, the Center for Medicare and Medicaid Innovation, where the demos, the Medicare Advantage demos come out of, the Medicare demos come out of, where they are really going to be pushing toward more ACO type models, prior auth potentially in the fee-for-service environment, or ways to get risk into Medicare fee-for-service with duals as one of the target populations. And I say this because yes, DSNP has been important. It's an important chassis. States are doing their thing. It's easier to think about that when someone is in the same health plan for Medicaid and Medicare. But now we suddenly might start to see some models emerging for duals who are in Medicare fee-for-service. This could be a really big thing. And we saw this, the first Trump administration had proposed this, it ended up not moving forward. We could see this rear its head again, and that could be an opportunity for states to grab some of the Medicare dollar for Medicare duals, Medicare fee-for-service duals, and work with their health plans. It could be an opportunity for providers or health plans to grab the fee-for-service dollar and coordinate in the Medicaid space. So generally, this, again, bipartisan, something is likely to advance. I'm not totally sure what, but if I were planning ahead for the next 12 months, I would be very much thinking about, like, what do I need to get in place for this ACO sort of managed fee-for-service, if you will, model? Because I don't think we're going to see any sort of diminishing of managed care. I think we're going to see an emphasis on managed fee-for-service, if you will.
Yeah, and I think along those lines, states have really been focused on managed care because of, budget certainty. And those of us that have been around a long time know that managed care brings a promise to actual focusing on outcomes and provides a really strong pathway around value-based care. And I think managed care, depending on who you talk to, and I talk to providers who sometimes feel, outside of that system, it is a system that can really provide incentives for providers to carry the burden they've always carried before. But I've also heard the same. And I think, I think from a state perspective, having, run a large state and having lived through MMP, one thing we learned through MMP is that despite the fact that we had some support on the federal partner side, we just weren't equipped. We spent our time just trying to wrap our arms around all things Medicaid, and then the notion of Medicare and trying to be fully informed and trying to be proactive in that regard, it can be a real challenge. So, I think to your point, we've seen expansion in DSNPs. We've seen a lot of states that are just mandating use of DSNPs in counties where their payers operate, and that seems like a worthwhile strategy to start. But I continue to feel strongly that, integrated care doesn't mean anything if the people, except for the people that are integrated within these common payers, if those parties are not working together and they're not focusing on how to really improve health outcomes and focus on cost avoidance, even including long-term services and supports, then integration does not look integrated. So I think there's tremendous opportunity. And I think whether it be from a cost savings perspective or however that looks. I think the message for people is that we have so much more to do before we can really say we've solved this issue around integration. I want to just pivot a little bit. I've mentioned value-based care. We've all talked about value-based care. And we know that Medicaid and Medicare certainly have provided a pathway, and states have been aggressive, and certainly payers have been aggressive on really trying to tie paid claims to value-based care arrangements that really incent providers and focusing on outcomes. And Julius, when you described your model, we know all of these efforts around value-based care are really in many ways addressing specific diseases and conditions. So I know you talked a little bit about the model that you operate, but in the same regard as Allie is, pulled her crystal ball out and tried to predict the future, I would just say to you, what advice would you give to payers and providers that are listening today and trying to figure out how to navigate the system?
Yeah, I think, I mean, the first thing is that I think that there is the move to value-based care. I think it's been around for a while. I think we've seen a number of primary care models do really well, and we've seen some other models do less well. But I think increasingly we will notice that there is a certain subset of conditions, notably, obviously, chronic kidney disease, where we've seen more success on the specialty side. And I would argue that increasingly, as dementia is really moving out of primary care into more specialty care, that this is really going to be the next area where it requires more specialty care models that are value-based. And so that's really where we see the guide model out of CMMI be a first attempt. It's not exactly value-based yet, but it is a great example for where Medicare and Medicaid dollars are really coming together in a way, because the guide model it's a new payment model. For those who are not familiar, it was introduced by CMMI in June of last year, of 2024, and it covers a comprehensive set of dementia care services, both spanning the spectrum from the medical side, so covering specialty care for dementia diagnosis and management, but also the social side, so covering a care navigator, respite care, caregiver support, and services that are traditionally more covered by Medicaid LTSS plans. And so that's sort of how we really see this as a great opportunity for health plans to, especially on the LTSS side, to essentially make use of this program to offset costs and to essentially directly avoid costs by essentially making use of these Medicare dollars. And so, there's sort of direct cost savings in the order of $3,000 per member per year by essentially directly offsetting those Medicaid costs with these Medicare dollars. So I think that's a great start. I think we're obviously hoping to see a lot more in terms of really truly creating specialty-based, value-based care models in dementia as of a condition that very much spans the needs of both Medicare and Medicaid plans.
That's great, Julius. And hopefully, when you look at all the diseases and conditions that are really being part and considered as part of value-based care arrangements, it really is impressive to see what the outcomes and what we'd say is the cost bend is on some of these categories. There are so many individuals that have conditions that have been poorly managed in the past, and now, not trying to boil the ocean, but focusing on some of these drivers that have a tremendous opportunity to affect outcomes. So
Exactly.
that's great.
Yeah.
Great. So I know we covered a lot of ground, and we have a few minutes left. And I realized I didn't even say who I was, this random person that was just, moderating the panel today. But I'm Gary Jessee, for those of you tuning in, and I'm a senior vice president at Sellers Dorsey, and have spent my career working in health and human services, and was just so excited to get to share the screen with Allie and Julius today. I just jumped right in. But as we get to the end of our webinar, we've covered a lot of ground. I just wanted to offer both of you, if you had any ending thoughts regarding effective dual integration. And it might be a loaded question, so don't feel compelled that you have to, talk forever. But just as you think about where we are and where we've been, Allie, maybe I'll start with you if you have any closing thoughts.
Yeah, I'm gonna tackle this in two ways. The one thing I will say is all plans right now need to be engaging their members, whether you are an integrated plan or not, whether you're a DSNP or regular Medicare Advantage. When we saw utilization skyrocket after COVID, but it has not gone down. So there is something more happening in the markets and engaging. There are requirements to engage on the Medicaid managed care side and on the DSNP side, but going beyond the requirements to really understanding what's going on. But I think in terms of effective integration specifically, it depends on who's telling you it's effective. Like, is it the person? Is it the provider? Is it the family member? Is it the government? Is it the health plan? I mean, to me, again, at the end of the day, it's following the money, and we need to align the dollars. Policymakers need to make whatever requirements they're making attractive to health plans and providers serving this population. Like, you don't want to disadvantage health plans and providers serving this population compared to those who aren't, or who are serving this population outside of integrated care. Like, you have to make sure you have a level playing field. That's one part of it. But then from like the state provider side or the health plan provider side, I would love to see some really provocative value-based care between long-term services and supports and acute care. So like some of the stuff where you were saying, Julius, like you said at the intersection, that's where we have that handoff between the Medicare payer and the Medicaid payer. And it's really hard when you've got a P&L, sitting over here on the Medicare side and a P&L sitting over here, and two people are owning them, to forge an integrated VBC. But that is where I think we need to see it happening right now. And not all duals have long-term care needs, but for those who do, that to me is the seat of where I think effective integration should be right now. And the population with long-term services and supports needs is only going up. Like, we are only seeing this population grow. This is not, the costs are not going to go down. The population is not going to go down. And we have nothing else in the country really that provides long-term care outside of it, unless you can pay out of pocket, right? So that's where I see the opportunity.
I agree with you, Allie. And, the thing I'd say for payers that are tuning in is, one size fits all approach to value-based care doesn't work. And when you get to long-term services and supports, those providers, they are so open and willing to really work through what is a suitable value-based care arrangement for the services they deliver. And because they're smaller, because the number of lives perhaps that they're managing is smaller, they're often neglected in terms of approaching for a really suitable model. So somebody's going to crack the nut on this, and we've seen some movement with the LTSS providers, but there's so much more to do. And they're ready and they're able and qualified, and really, you think about it, they are in the homes and taking care of people all day long. And who better to really help be the eyes and ears of that solution in terms of the structure around value-based care. So Julius, I wanted to make sure we have just a couple of minutes, but wanted to offer you some closing remarks or any thoughts you might have.
Yeah, no, thank you, really, both of you, for some amazing insights here. I think one of the key learnings from me from this session really is that, providers and population health really play a critical role in the integration between Medicare and Medicaid. I think it's very difficult often for a health plan to integrate both sides effectively, and that's where sort of a population health program can really help a lot in just creating one aligned care model that really works across both areas of spend. And so, yeah, I think I'm very excited, especially obviously for the area of dementia. That's my particular area of interest, but in terms of how we can really support health plans integrate between the two. And I think that there's a vast opportunity, and so let's work together on sizing the opportunity and aligning the incentives.
I think that's incredibly helpful. mean no pressure, but there are countless individuals that are depending upon all of us within this healthcare system to make it happen, and they deserve that attention. So I think this is the shortest webinar I might have been on in a while, and certainly I'm a talker, and it's probably the shortest that I've ever moderated, but I wanted to just extend my appreciation to Ali and Julius for joining me in this conversation. Certainly a lot going on, and we'll all be paying attention. But those of you that tuned in, please keep up the good work, and look forward to hearing from any of you should you have questions or need additional information. So I think that is it for us, and we're right on time. So have a good rest of the week.
Fantastic. Thank you, everyone.